Acute kidney injury is exactly what it says on the tin. It's an acute sudden reduction in kidney function with evidences in changes in lab values, so like creatinine and urea, and reduction in urine output, okay? There are multiple causes of this, okay? We'll talk about some of them. There are multiple causes. Let's talk about some classification to start with. How do we classify how much AKI or how bad somebody's acute kidney injury is? There's a couple of ways. There's a couple of different scoring systems you can see there. There's a rifle scoring system. There's a Aiken. There's also the KiddiGO. The key thing is they're measuring two things. Number one, they're measuring your creatinine. Your kidneys filter creatinine out of your body. So if you have a raised creatinine in your blood, it shows that your kidneys aren't working, right? So the first criteria here is like increase by 1.5%, or 1.5 times, 2 times the normal level, 3 times the normal level. You can see it's getting worse and worse and worse as the creatinine level increases. So that's the same for both of these. And the second thing they all measure is urine output. Your kidneys produce urine. If you have an acute kidney injury, your kidneys stop producing urine, okay? You can't move the fluid out of your body. You can't move the junk, the urea, the creatinine out of your body because you can't pee. Your kidneys aren't peeing. So as your acute kidney injury becomes more and more severe, your renal output, your urinary output decreases, okay? So you can say, less than 0.5 mils per kg in 6 hours, less than 0.5 in 12 hours, in 24 hours, and similar thing here. Okay, so it doesn't matter which one you use, really. Your different departments will have different preferences, but really it's based on creatinine, okay, and your urine output, okay? So that's basically it. And there's overlap between them. So that's how we classify AKIs. But causes, okay? So the causes of AKI, right? Pre-renal, intrarenal, and post-renal. Pre-renal is something that happens not in the kidneys. It's not a kidney issue. You've either lost a lot of blood, you've become suddenly dehydrated, your heart can't pump blood properly, you've got liver failure, something else is happening in the body that's causing damage to the kidneys. And I'll tell you why. Your kidneys at any time have 20% of the blood in your body. 20%, that's a lot, right? And so they're very, very sensitive. They're very sensitive to low blood or low volume levels. Your kidneys get very quickly very damaged if you become severely dehydrated, or if your heart can't pump the blood properly, or if you have a stenosis in the artery of the kidney, which means blood can't come in sufficiently. They're very sensitive. So things like dehydration, stenosis of the renal artery, liver failure, heart failure, these are all pre-renal causes. Then you have intrarenal causes. This is a bit more complex. We'll come back to this in the end. Let's talk about post-renal. Post-renals, you just can't move the urine out. You have a physical obstruction of some sort or injury after the renal calyx. So either you have a tumor compressing on the urethra or the ureters. You have a bladder tumor that's stopping the urine from going out the way, so it goes back up into the kidney, causes backflow, causes pressure on the kidneys. You have a renal stone. You have an infection that travels up the ureters and into the kidneys and causes severe damage. These are all post-renal, very, very common. BPH, common elderly gentlemen, prostate enlarges, can't pee out as much, urinary retention, blockage of the urine, and then basically goes back up into the kidneys and causes infection, causes hydronephrosis and stuff like that. Okay, let's talk about intrarenal. This is where the complex stuff comes in. There's 3 categories, okay? Listen to me. This took me a long time to understand, so please just listen. Okay, there's 3 categories. We're going to start with the easiest one. Intrinsic renovascular disease, right? So this is the similar to pre-renal. So dehydration or some sort of renovascular disease, okay? Like stenosis or something like that. You have glomerulonephritis, your glomerulonephritides, you're basically, you can have like, what's it called? Goodpasture syndrome and other glomerulonephritides that there's an autoimmune reaction of this autoimmune reaction to different parts of the glomerulus that causes damage to the kidney and causes AKI or acute kidney failure, and there can be triggers for this autoimmune reaction. And then there's a tubular interstitial disease, and these are 2 types. There's acute tubular necrosis, which is caused by significant toxins. So if you have like a certain drug that can injure the kidneys, like excessive levels of NSAIDs or something, or if you, not even necessarily drugs, but like myoglobin, if you have an excessive breakdown of your muscle and then you have too much myoglobin and your kidneys have to filter that out, that can cause ATN. And you have AIN, which is a allergic reaction. Acute interstitial nephritis is an allergic reaction, okay? So this is like if you take a drug that you're sensitive to or your kidneys are sensitive to, not the same for everyone, you'll get an AIN, acute interstitial nephritis, which means that your kidneys will have like an allergic type of reaction, which will cause damage intrarenally, okay? So these are the three kind of intrarenal categories, and you can read about them more in detail. But we're just going to talk about how we manage an AKI in general, because they'll all present with the same AKI. They just have different causes of the AKI, okay? So at the end of the day, you need to treat the cause, but you're also managing the actual AKI, which is what you as an FY1 will be doing before they get moved to a renal ward. Okay, so acute kidney injury. This is an extract from a textbook that I have, and it's basically talking about the same stuff I talked about: pre-renal, post-renal, and intrarenal, and it goes into a bit more detail about the kind of finding that you find. But you don't need to know this much; you just need to know how to manage. Diagnosis, right? So, how do you diagnose an AKI? You basically do a couple of things. There's not too much. You do blood tests. That's it, really. You do a blood test and you do urine analysis. So if I want to diagnose someone and I want to confirm they have AKI, I use urea and electrolytes. That'll tell me what the eGFR is and what the creatinine is. So if the creatinine is 2 times or 3 times the upper limit of normal, then I'll be like, okay, this guy definitely has an AKI. And then I monitor their urine output. So I either put a catheter in or I ask them to pee in like disposable cups and stuff like that, so I can see how much urine they're producing. Because if the urine output is 0, if they're oliguric or auric, then that means their kidneys are busted, right? They're not producing urine. So those are the two kind of diagnoses as such. But you also want to do a volume assessment. So you want to see if they have edema. You want to do their observations. You want to do a urine analysis, not just for the creatinine, but you also want to do a urine analysis for infections. So you might want to do an MSSU. You can do a GN screen, so glomerulonephritis screen. So you check for all these autoimmune antibodies, so ANCA, ANA, GB, GBM antibodies. Rheumatoid factor C3, C4, which is related to like sarcoidosis. What is it related to? Lupus is related to lupus. Okay, and then you can do a virology screen as well. So there could be an infection. So hepatitis B, hepatitis C, HIV. These can all cause AKIs. And you have to rule out sepsis, so you can exclude obstruction. You can basically check, you can do a scan, an ultrasound of the bladder and kidneys to see if there's anything compressing and it's a post-renal cause. You can look at the drug history to see if there's an intrarenal cause causing acute interstitial nephritis. Remember I told that's an allergic reaction of the kidneys, right? So you can look for these things, right? So that's what we want to see. And how do we manage it, right? Listen, this is what you need to know, right? If their volume deplete, give them fluid. Don't just give them fluid straight away, right? If they're overloaded, if they're swollen like a balloon, if they have fluid in their ankles, in their tissue, and they're overloaded, and they have peripheral edema and central edema, and they've got fluid in their lungs, do not give them more fluid, okay? Because they have plenty of fluid, they just can't pee out. If they're dehydrated and they don't have enough fluid, then you can give some fluid, all right? If they're hypotensive, but also overloaded. You know how when someone has a low blood pressure, we're like, oh, give them fluid, their blood pressure will come up. But if they're low blood pressure and they're overloaded, i.e. they have all this fluid in their tissue and in their lungs, you don't want to give them more fluid, but they have low blood pressure. You can give them inotropes to make their heart work harder so that their blood pressure can come back up. If they're hyperkalemic, you need to basically, it's an emergency. We've talked about this. You can give them calcium rosonium to stop potassium absorption. You can give them calcium gluconate to stabilize the cardiac membrane, insulin dextrose to push the potassium back into the cells out of the blood. And then you treat the underlying cause. So for example, if it's a glomerulonephritis, you usually give them high dose steroids. If it's a UTI, you give them antibiotics. If there's a tumor compressing on the ureter or the ureters or the urethra, you contact urology or surgery to see if you can relieve the obstruction. You can give them nephrostomies instead. And then the last resort, usually the last resort, is dialysis, okay? Dialysis, I love dialysis. I love dialysis so much, right? When do we give dialysis? When do we give dialysis? There's specific criteria. Not when they have acidosis or electrolyte derangement, overload, or uremia. This is every person who has AKI will have all of these 5 things. It's when they have persistent acidosis. So they came in with acidosis. We know they have an AKI. We've treated it, but it's still acidotic. We treat it, it comes back. Treat it, comes back. Persistent acidosis, persistent electrolyte derangement, intoxication with certain drugs that we can't remove from their body or we can't chelate, persistently overloaded. So we remove the fluid from their body, their lungs fill up again. We remove the fluid from their body, their lungs fill up again. And then uremia, constant uremia. So if they're not resolving and they have this AEIOU, acidosis, electrolyte, intoxication, overload, uremia, persistently, recurrently, then you give them dialysis. And dialysis is a miracle. I swear to God, before dialysis was around, these people would die. There was nothing else for it. There was absolutely nothing else for it. If someone had an AKI, if they didn't start peeing soon, they would die. So what do the renal consultants or the renal registrars do? They put a line in to one of their big veins or big vessels, like their subclavian or their femoral. They put a central line in, and then they take the blood out of their body. See this little tube here, this pink tube, that's their kidney. That's the kidney of the machine. This blood goes to this kidney, goes through a membrane, gets filtered across a membrane with another fluid, and then it gets propped back out, going around the machine and back into their body. Okay, it's basically an external kidney, and it's an absolute miracle. The number of lives this machine has saved is unaccounted for. Before this, anybody who had a kidney issue or couldn't find a donor would just die. There was nothing else. People would die in their 20s, in their 30s. That would be the end, right? So dialysis is a miracle. So that's how you last stage of management of AKI. All right. And what you're looking for is you're waiting for liquid gold. So as soon as they start peeing, you're like, hallelujah, kidneys are working again. You just want to monitor the urine really carefully to when they start producing liquid gold. Okay. And recovery can take time, but what you need to remember is that when they recover fully, they might not be back to their baseline. So they might have had a normal EGFR of 60 plus, but when they recover, their EGFR is not 60 plus anymore. There's 50, and they'll stay at that level. That's their new baseline. Okay.